Warm greetings to one and all. Let's wait for a couple of minutes while we admit the rest of them. Hope you all can hear my voice clearly. So once again, this is Dr. Anita Sarjan, your MC for the session. If you wish to claim your certificate for the same, kindly visit our website, which is www.onlinedentistry.in, or register for the same. Online dentistry has been the pioneers in providing dental education via both online and offline platforms. It has been over 14 years that online dentistry have been conducting sessions for clinical practitioners across the globe. Established in the year 2008, so far we have covered over 203 offline courses and have conducted over 1,022 online courses with an enormous amount of more than 30,000 followers on our platform. Let me proudly introduce the CEO of online dentistry, Dr. Binuti Abraham. He's one of the finest practitioners in this town, an orthodontist by profession, a passionate photographer, and he owns his private practice at Kerala Dental Clinic, Aluva. Moving on to the academic head of online dentistry, Professor Dr. Joby Peter. Currently, he's the HOD of Department of Pediatric Dentistry at Anu Dental College, who preaches the philosophy to catch them young and watch them grow. Over the years, we have grown dynamically, launching 10 centers in different parts of India. On popular demand, we are relaunching our next 3-day session on November 24, 25, and 26 at Cochin. The latest addition to our courses, the 1-year comprehensive and advanced master training program on interceptive and myofunctional orthodontics, have been successfully initiated with 2 batches. So this is a multidisciplinary approach with intense training and hands-on session. The program is now a fellowship program on interceptive and myofunctional orthodontics, which is accredited by the Manipal University College, which is a sister concern of Mahi University. Herein, 2 of the modules will be happening in Malaysia, along with the graduation ceremony and a certificate distribution as well. We are a batch full now and are awaiting registrations for 2024 batch via our website. You can always feel free to reach to us on our WhatsApp number or visit our website, which is www.onlinedentistry.in, or else you can mail us on onlinedentistry.in@gmail.com. Online dentistry have been conducting sessions all over India for the past 14 years. During the lockdown, we started conducting online sessions to benefit the practitioners, which have been received with great appreciation from the dental fraternity. In the year 2023, we are relaunching the same by providing free advanced learning CDs under the title Online Dentistry at 9 p.m. Without further ado, let me move on to introducing the speaker for the day, Dr. Kavitha. Dr. Kavitha is a passionate pediatric dentist practicing exclusively pediatric dentistry at her clinic, Innocent Smiles Dental Clinic at Ernakulam since 2012. Her clinic is now a reference center for challenging pediatric cases under nitrous oxide oxygen inhalation sedation. She has completed her BDS from GDC Mumbai in 2007 and MDS in pediatric dentistry from GDC Trivandrum in 2011. Dr. Kavitha is an eloquent speaker and has delivered keynote address at both national and state platforms. Her keen interest in training postgraduates has made her one of the most sought-after trainers for postgraduate students at national and state levels, postgraduate orientations and rapid review programs, for also quiz competitions as well. She has recently received the Distinguished Woman Award from the Indian Society of Pediatric and Preventive Dentistry. Her areas of interest include minimal invasive pediatric restorations and endodontic procedures in primary and young permanent teeth. So proudly welcoming the star of the session, ma'am, the session is all yours now.
Thank you so much, Dr. Anita, for those warm words. Can I start with my screen sharing?
Yes, ma'am. Yes, ma'am.
Okay, so very good evening to one and all. Thank you so much, Online Dentistry, for having me over today. So what am I here today for? I'm here to make some noise. Right? What exactly is this noise? Like whenever I go anywhere, as a pediatric dentist, the first word that is associated with me is obviously noise. But is that the noise that I'm going to be making today? No, it's a different kind of a noise, right? So as we go ahead, I'll take you through this noise. So welcome to Innocent Smiles. This is my practice at a place called Mavilipuram in Kakanad, Ernakulam. I started my practice way back in 2012 and now it's my 11th year of practice. This is my clinic where I practice conscious sedation. I've been doing that for the past 3.5 years, going to be 4 years since I'm practicing conscious sedation at my place here. So this class, I'm going to take you through the different aspects of conscious sedation, how I started, what were my fears when I actually started, when I actually was about to start using nitrous oxide oxygen inhalation sedation in my practice, how I overcome all those fears, and how now it actually benefits me and how my GA cases have become almost close to very, very, very few thanks to nitrous oxide oxygen inhalation sedation. So again, as I said, when I talk about pediatric dentistry, this is the picture that comes in front of all of us, right? We have a child. The child needs some dental treatment. And this is how the child is going to be looking at us, right? And this is what makes all of us scared to practice pediatric dentistry. How will I manage this? How will I take care of this little thing? Though little is going to make a big mess in my clinic. How exactly will I go ahead, right? So what exactly comes to our help? Is it always nitrous oxide oxygen inhalation sedation? No, that's what my class is going to tell you. It's going to open your eyes that the crux of pediatric dentistry is behavior management. If you cannot manage a child's behavior, then your appointment will be a failure, whatever advanced technique, equipment, or material you use. So the basis of pediatric dentistry is behavior management. And in 1895, Elroy came up with these beautiful words. Although the operative dentistry may be perfect, the appointment is a failure if the child departs in tears, right? So this is something we all should remember when we are trying to deal with children. And this approach, which argues that success of dental treatment in pediatric patients depends upon the attitude created in the children rather than the technical or clinical evaluation, is even supported by our American Academy of Pediatric Dentistry guideline. Now, we pediatric dentists, we follow guidelines which have been given by AAPD. That's like the god of guidelines in pediatric dentistry. And they too have affirmed on this principle that a dental appointment in a child is a failure if a child departs in a torrent of tears. So when you look at the spectrum of behavior management, the first and foremost or the most part of the spectrum is occupied by communicative behavior management. Then it goes ahead to audiovisual distraction and then goes to nitrous oxide oxygen inhalation sedation. So these are the three areas that make up most of our behavior management. A large part by communicative guidance, a small part by audiovisual distraction, and an even smaller part by nitrous oxide oxygen inhalation sedation. So if you see the spectrum itself, you'll understand that almost 75% of the cases can be managed like this. And very few of them tend to go to the end, that is towards general anesthesia. And that is what my efforts aim at these days, trying to reduce the need for excessive general anesthesia in very young children. So how is that possible along with communicative behavior management, along with my strategies that I use to manage child's behavior? We have something called as pharmacological behavior management. So what exactly is this pharmacological behavior management? It is a very broad term that is used to describe the use of drugs to manage the behavior of pediatric population undergoing dental procedures. So how all can we do this pharmacological behavior management? We can do it by inhalation. That's what nitrous oxide oxygen does. You can do it by oral routes, intranasal routes, intramuscular routes, and intravenous routes. So when you see the spectrum of pharmacological behavior management, you have again various levels. Anxiolysis, anxiety. Then you have anxiolysis coupled with an interactive level. That is, your child can interact with you. Am I audible, Dr. Joe?
Yes, ma'am.
Yes, ma'am, you're audible,
Yes,
ma'am.
ma'am. You're audible, ma'am.
It says my internet connection is unstable. I hope there's no problem, right?
No, ma'am. It's going well.
Okay, thank you. So when you come and look at the spectrum of pharmacological behavior management, you start with anxiolysis, then you're in an interactive level, then you go to a non-interactive level, then arousable level, and then you go to a non-interactive, non-arousable level, right? So in 1985, we just had 3 different categories: conscious sedation, deep sedation, and general anesthesia. But now we have something called minimal sedation, moderate sedation, deep sedation, and general anesthesia. So whenever you are practicing conscious sedation in the clinic, one thing that you need to remember is that your patient should always be in the 2 levels, either minimal sedation or moderate sedation. He or she should not enter the deep sedation or GA mode. That is, he can have anxiolysis, he can interact with you, or he could interact less but be arousable by some kind of a stimulation. But never take him to a level that the patient becomes non-interactive or non-arousable. This is when you're doing nitrous oxide or when you're doing pharmacological behavior management in a clinical practice. Okay, now what you need to remember about nitrous oxide oxygen sedation. Nitrous oxide oxygen is never going to take your patient beyond this interactive level. It will not even take your patient to non-interactive arousable level. So that is the beauty of nitrous oxide oxygen inhalation sedation. You can safely practice it in the clinic. It's never going to take your patient to a non-interactive level. But if you mix nitrous oxide with other agents, be it oral, IV, IM, or even intranasal midazolam, then you need active monitoring and you need good life support. And you need to be trained in delivering all this to the patient. See, just having life support in your clinic and putting a tick mark that, I have all the life support now, I can mix all the drugs and work, is not going to work. You need to have all the life support and you need to be trained to deliver it if, God forbid, you have any such emergency in your practice. So what I do is I always restrain my pharmacological behavior management to just these 2 levels, anxiolysis, interactive level, wherein I am not taking the patient to a level where he is non-interactive and needs painful stimulation to be aroused, right? So this makes your practice very safe. And when you're practicing in a safe environment, obviously your confidence also increases. So listening to me, is this how most of you are sitting? I hope not, right? So what exactly, why is it called sedation? Now, pharmacological sedation is mediated by administration of an agent or a combination of agents causing alterations in the level of consciousness, cognition, motor coordination, degree of anxiety, and some physiological parameters like pulse rate, heart rate, breathing, respiratory rate, right? So all this is an interplay, and that's what sedation is. So when you come to sedation, you have two again words that you need to remember. One is conscious sedation and other is deep sedation. And I have just highlighted the principal difference. What is it? Respond purposefully to verbal commands. That is what conscious sedation says. I have a message in the chat box at around 9:15, that's a minute back, which says audio is not audible. Is it true?
Actually, we can hear you, ma'am.
We can hear you clearly, ma'am.
Okay. Okay, so then I think the doctor has to fix her speaker or something, right? Yeah. So coming back to conscious sedation and deep sedation, the principal difference here is in conscious sedation, patients respond purposefully to verbal commands either alone or accompanied by light tactile stimulation. That is, you just need to touch the patient, or you just need to wave in front of the patient's eyes. Simple commands will give good responses. Whereas in deep sedation, patients cannot be easily aroused but respond purposefully following repeated or painful stimulation, right? So this is the principal difference, and you should understand the safety difference also. A patient who can't be easily aroused and needs repeated painful stimulation is not a very safe patient to have in the clinic. Whereas a patient who can respond to verbal commands and can be easily aroused by light tactile stimulation is a very safe patient to have in your practice, right? So always remember, when you are practicing conscious sedation, try to limit your patient to the first two levels, right? That is minimal sedation or interactive level. So what exactly is minimal sedation? It is a drug-induced state where the patient responds normally to verbal commands, although cognitive function and coordination may be a bit impaired, and this is what we make use of. So it is just a bit impaired cognitive function, which we, along with our behavior management technique, make use of and get the patient accept our dental treatment, right? So this scene you should be reminded when you're doing conscious sedation, right? Behind every angry man, I mean every angry woman stands a man who has absolutely no idea what he did wrong, right? You get up in the morning and your wife tells you, do you remember what date it is and the state that you're in? You're trying to think what date it is. Is it her birthday? Is it our wedding anniversary? Is it something that I had told my wife and I'm not doing it, right? And it is at that point where you're not sedated. You can easily interact, but your mind has gone somewhere else, right? It is exactly that situation that your patient falls into when you're doing conscious sedation, right? He'll be a bit detached from the surrounding, but very much inside it. So which level of sedation you should reach, I want you to all just remember this one picture, and that will give you a good idea where your patient should be taken to. Okay, so when coming to the responsiveness, as I told you, it will be normal in minimal sedation, purposeful in response to verbal alone, accompanied by light tactile stimulus in moderate sedation, and to painful stimulus in deep sedation, and patient will be unarousable in GA. The airway also can be easily maintained in minimal sedation. The ventilation is not affected and the cardiovascular function is not affected. So this is the level, the first table that nitrous oxide can take your patient to safely, can also take to level 2, but that is on higher concentrations of nitrous oxide. So you should understand that the ventilation and the cardiovascular function are not affected. So airway also is unaffected. So you have a very safe patient in front of you, and you don't have to be scared of doing this in your practice. So just quickly going into the historical perspective, actually there's a book on nitrous oxide Right? It's a very, very good book written by Clark. And all of you must, if get an opportunity, read it. And that has given the history of nitrous oxide very beautifully. So Sir Joseph Priestley was the one who initially found out nitrous oxide. He called it dephlogisticated nitrous air. And he also incidentally found out oxygen, and he called that dephlogisticated air. And there's a lot about it. There's a lot about how Humphrey Davy did the experiment on nitrous oxide, and how he bought nitrous oxide from Colton, and how Horace Wells, the dentist, who's first attributed to using this in a setup to extract a tooth, is all very beautifully given in this book, right? So you all must, if possible, if you get an opportunity, do read about the history of nitrous oxide. It's extremely interesting. So how does this nitrous oxide work? Very, very simple mechanism of action. It has an analgesic action because it releases endogenous opioids. It has an anxiolytic action because it activates the GABA receptors. And it has a mild anesthetic action, which is related to the antagonism of NMDA receptors. Now, this is not very soluble in blood. So that attributes it to the quick onset. So if a drug is not very soluble in blood, it will very quickly penetrate and enter the brain. So the reduced solubility and the increased blood gas partition coefficient, very quickly it will come from the lungs to the blood. These two characteristics help to get a very quick action of nitrous oxide. Okay, so what happens on inhalation of nitrous oxide to the lungs? It has a rapid uptake, it is quickly absorbed from the alveoli, and it is held in a simple solution in the serum. And then what happens? From there, it enters the other tissues of the body, such as the central nervous system. And when it reaches the required concentration, it will produce sedation in varying levels among individuals. So you breathe in the nitrous oxide, it goes to the lungs. From there, goes to the blood, crosses the blood-brain barrier and reaches the brain. And that depresses the cerebral cortex, which is the main action of nitrous oxide. So also, when you exhale all the nitrous oxide out, it is rapidly excreted out of the lungs. And once N2O is no longer inhaled, whatever is present in the other parts of the body will rapidly pass down the gradient into the bloodstream and out of the body via the lungs. So that is again the beauty of this material. It doesn't stay accumulated inside the body. So it's not going to cause any toxic effect on any part of your body. So again, it's very safe to be used in your clinical practice. So everything that I'm telling you should increase your confidence in the safety of using nitrous oxide in a dental setup. So as it goes out, it goes from the brain to the blood, gets into the lungs, and the patient breathes it out. Nothing remains in the body. And that's why when parents ask you, how long will the effect remain? Can my child go to school after this? For initially, I used to, I wasn't sure whether all this that I'm reading is true or no. But now I'm very confident, and I confidently tell the parents that you can send your child to school after the procedure. There is absolutely no problem. There's going to be absolutely no change in the child's behavior, which is something which the parents have started accepting now, right? When we tell them that the effect will stop as soon as you stop the gas, they can actually see it happening in the child. The child will be minimally sedated when the child is inhaling nitrous. And as soon as I start delivering oxygen towards the end, the child will start moving back again. So this is the beauty of conscious sedation. Remember that it is the least potent of all anesthetic gases because it has an MAC of 105. That is 105% of the alveolus should be filled with nitrous oxide to get an anesthetic, to get general anesthetic effect. And that is never going to happen. 105%, that is more than 100% of the alveoli can never be full with this gas. And you should remember that a second gas effect will occur if you administer other anesthetic agents with it. And that is when you need to be careful, not when you're doing it alone. Right? So what are the disadvantages? Why am I stressing so much on this route of administration over the other routes of administration? I told you there are other routes like oral, intramuscular, intravenous, intranasal, right? Oral, you cannot titrate the drug. But in this, I'll show you how you can slowly increase the percentage of nitrous, how you can reduce the percentage of nitrous. You can delay the onset. You can vary the response, right? Anything you can do in this technique. Whereas in oral, you just have a fixed dose. You can't titrate the drug. You have to wait for it to act. You will not get a quick, rapid action. And oral reversal drug also is not present. Whereas if you give inhalation, I told you, as soon as you stop the drug, the effect is stopped, right? And also longer pre-procedural fasting is required for oral route. Intramuscular, intravenous. Well, we do all this because we are scared of the needle and the child combination together. So the whole point of doing an intramuscular or intravenous goes away for me over here itself. But obviously, these are the disadvantages. Intramuscular is difficult for patients who are needle phobic. It can cause muscular pain. Over sedation is possible, right? And same thing in intravenous also. Intranasal, though not as difficult as the other routes, still because it is highly vascular, over sedation is possible with the intranasal route also. Midazolam is the drug which is used intranasally. So what are the advantages of nitrous? It has a fast onset. It is very easy to administer. The sedation level can be adjusted based on responses. The duration can be adjusted. The recovery is very quick. And what is the beauty? The patient can communicate even when he is undergoing nitrous oxide oxygen sedation. That I feel is very beautiful. Any kind of discomfort, anything bad the patient is feeling, he can easily tell the operator and we can terminate the procedure, right? So that is again a beauty of nitrous oxide. It is very safe compared to other agents, and as I said, it has no impact on daily activities. So once you know that it is safe to use, once you know how the mechanism works, what is exactly happening, how it is entering the body, how it is exiting the body, now you need to know who are the ideal candidates for using nitrous oxide. Well, children who have fear or anxiety, right, who are needle phobic. Now you should concentrate on these words, fear and anxiety. Okay, needle phobic, where profound local anesthesia cannot be obtained, like acute pulpitis, patients who have a gag reflex, hypoplastic teeth, enamel hypoplasia, molars, which are a little difficult to anesthetize. Nitrous oxide helps like anything. Prolonged or unpleasant treatment, especially surgical extraction. See, however cooperative the child is, when you have a canine impaction, experience for the child. So if you do it under make it a pleasant experience for the child. When there is a history of persistent fainting, and as an alternative to GA for some special needs or medically compromised children. Okay, so these are the indications for your nitrous oxide inhalation. Now, it can also be given in patients with cardiovascular disorders, with liver and kidney disease, with sickle cell diseases or trait, or in patients with cerebral palsy. So you have a multitude of places where you can use nitrous oxide sedation. So I have a question that, can it be used for anxious adults? Yes, you can use it for anybody who is anxious. Adult or child is not the criteria. But let me just finish this. The criteria is anxious patients. It doesn't say hypermotive, or it doesn't say patients who are crying with torrents of tears, who are kicking around, who are so difficult that you can't even put them on the chair. They are not going to accept the mask, right? So you need to modify the child's behavior, get it to a level that he's only anxious. It cannot be used in a child who is throwing temper tantrums, who's kicking his foot around, crying very loudly. These patients are not good candidates for nitrous oxide. So, for doctors who feel that they need to manage kids who with such disruptive behavior using nitrous oxide, then no, I have bad news for you. That is not the ideal patient for nitrous oxide. The ideal patients are those patients who are just a bit scared. I'm scared, doctor. Or the patients who go and hide behind their mothers. They don't show disruptive behavior, but they are scared, and they will benefit because they won't have any bad experience with the clinic. So a child who is maybe in the negative, not definitely negative for sure, negative or maybe a positive child is an indication for nitrous oxide oxygen sedation. Not definitely negative child. Stubborn, hypermotive children are not ideal candidates for nitrous oxide, and this is the mistake most operators make. They try to use this as a magic potion to every child who comes to the operatory. So that's not how you use it. You need to select your patients. Only anxious ones will benefit from nitrous oxide. So when do you say no to nitrous oxide? You say no to nitrous oxide in those kids who have an inability to communicate. Because as I told you, communication is the crux of nitrous oxide. They should be able to freely tell you their feelings. It doesn't take you to a level where you cannot communicate with the patients. So a patient who is not able to communicate is a contraindication for nitrous oxide. Very young children, again, I don't use nitrous oxide. Fear of the mask. Well, to some extent, this can be counteracted by repeated behavior management. You can make the children come out of the fear of mask. And mouth breathers obviously are strict contraindicators because you need to breathe through your nose to get the gas. If you're a mouth breather, you will not be able to breathe through your nose. You will not get any gas and it will be very suffocating. So you will not get sedated. So children who are not getting sedated, you can even suspect mouth breathing in such children. Severe muscular depression, severe psychiatric disorders, behavioral or personality problems, learning difficulty, first trimester of pregnancy are all a contraindication to nitrous oxide. Those children who are unable to breathe through their nose, they have a cold, nose is blocked, then always postpone the procedure to another day when they can breathe better to their nose. Those children who have a history of otitis media. Why? Because see, nitrous oxide has a very high partial pressure. It is 34 times that of nitrogen, right? So 34 times means when you have a closed space infection in your body and you give nitrous oxide, this nitrous oxide goes and occupies that air infection closed space and tries to push the cavity. So that gives intense pressure in such cavities, be it the maxillary sinus or the eardrum or any obstructive bowel disease, any kind of thrombus in the body. All that is a contraindication for using nitrous oxide oxygen inhalation sedation, right? So here, as I just for a change, a question, which patient is a contraindication for nitrous oxide? So obviously I have almost given out the answer. It's obviously the patient with acute sinusitis, because as I said, sinus is a closed cavity, and when the patient has sinusitis, the patient is going to feel intense pain in either the maxillary region or the forehead region when I give nitrous oxide. And in fact, I've experienced this with many adults who have sinusitis, right? When they come and take nitrous, they say they have a headache. That is because your nitrous oxide is pushing these air-filled chambers, getting inside these air-filled chambers and pushing the air out. And that is done with intense pressure. That is why these patients are a contraindication to your nitrous oxide oxygen inhalation sedation. Right? So this is a picture that you need to remember on the contraindications of nitrous oxide. So what are the systemic effects of nitrous oxide? they increase the respiratory rate and diminish the tidal volume, anesthetic gases, right? But the increase in rate produced by nitrous oxide actually will provide an increase in minute ventilation. So for moderate cases, it does not depress the ventilation really. And when it is combined with sedatives or opioids, that is when it depresses the ventilation. So this kind of combinations should not happen. And cardiovascular effects mildly depressed myocardial contractility, but however, it is not very severe with these gases. Well, in the central nervous system, that is the main area of action, it depresses the cerebral cortex. It does not produce any relaxation in the skeletal system, right? On its own, it doesn't produce any relaxation, but the patient is relaxed, and that is why the skeletal muscles also are relaxed. Okay, so these are the systemic effects of nitrous oxide. So let's go to the stages in which a patient passes through when he is given nitrous oxide. The first is plain one, where there is slight analgesia and amnesia. So the patient has loss of fear and anxiety and a warm tingling sensation. Mind you, never tell the patient what he is going to feel when you are giving nitrous oxide. Now, again, a mistake which I feel many people do, they keep asking the patient, are you feeling tingling? Are you feeling floating? See, all patients need not feel all those effects, right? The only area which you need to concentrate when you are giving nitrous oxide is the patient's eyes. And trust me, this is what I have learned over 4 years of sedation practice. Just look at the patient's eyes. As soon as the patient enters plain 2 sedation, there will be a change in the appearance of the eyes. And that is what you need to catch and start your dental procedure. So always start your dental procedure when the patient reaches plain 2 of sedation. What is that? Moderate analgesia and amnesia. Where the patient is relaxed, they can maintain open mouth and follow instructions. Voice changes character. Eyes appear glassy. They are very concerned or connected with the surroundings, and there is a decreased motor coordination. This is the perfect level for you to inject, give that anesthesia, start your treatment, do your access opening, or maybe open your flap for a wisdom tooth extraction. This is the plane that you need to achieve. And how will you achieve it? Just looking at the patient's eyes. That's it. Don't ask the patient any question relating to, tingling in the extremities or anything of that sort, because then the patient becomes more alert, becomes more conscious that I'm not feeling any tingling. I'm not feeling any tingling. Tingling is not at all important, right? The eyes will tell you whether the patient is in plane 2 of sedation or no. Plane 3 is complete analgesia. Mandible becomes rigid. It becomes difficult to open the patient's mouth. There's a sensation of flying. The patient appears sleepy over glassy, right? There's a dazed, staring look, does not follow directions. And some patients, especially children, they become uncomfortable. They start becoming hypermotive. So you will have a child who will be cooperative for some time. And if you increase the amount of nitrous given to the patient, because you have not judged the level of sedation, suddenly they will become uncomfortable. They will start crying. They will become cranky. They'll start moving a lot. That is when you should understand. A child who is almost sitting okay suddenly starts moving a lot. It means that you have over sedated the child. So that is when you need to reduce the sedation a little bit. So how does the patient move through? General appearance, you look at the patient, he will be comfortable and relaxed. There will be reduction in spontaneous movements, especially the shoulder, the forehead. The forehead, it will not have any wrinkles. It will be very, very relaxed, right? And the eyes of the patient will be glassy. The blink rate will be very, very less. Okay, so these are the things that you need to concentrate. If the patient is sitting cross-legged, he will open the legs more often. He will open the legs because he's relaxed. He or she, whoever, is relaxed. And this, mind you, not only with children, it happens with adults also. Anyone who is being sedated will have a glassy appearance in their eyes when they reach stage 2. So now let's look at different eyes of patients. right? I have a picture here, which is picture 1, and I have a picture here, which is picture 2. So which do you think is a glassy appearance in the eye, where the patient is not alert? I have tried to make it, yeah, I'm getting answers 1, 1, 2. I'm getting both of them, right? So you all are confused. I'm getting 1 and 2 both in my answers. That's a good thing. But I'm getting more of 1. And yeah, so I'm getting more of 1 and less of 2. So is it 1? Now when I say this, I'm getting a lot of 1. What if I tell you 1 is the wrong answer? Then will I get 2? So yeah, again, I want all of you to concentrate on the eyes of the patient. Look at the eyes in picture 1. They are so glassy. Can you see a glassy tint in the patient's eyes? And also this patient doesn't seem too bothered of what is happening around him. Whereas you see the patient 2, he's quite alert. The eyes are wider open than in the earlier picture. So this subtle difference is what you should be making out when you are sedating people. Which kind of mask I use, I'll tell you slowly about the mask. I use a low profile mask, right? Now look at this child. There are stages through which this child goes. This is one picture. Can you concentrate on the forehead of this child? Can you see a wrinkle over here? Can you see the eyes also? The child looks alert. He looks as though he's looking at me. Whereas look at the child now. Look at the forehead. He's so relaxed. Look at the eyes. This glassy appearance of the eyes can tell you that this child has gone into plane 2 of sedation, right? And look at this girl again. Now this girl here, look at her eyes. They look completely normal. They don't look glassy at all. Look at her here, right? This is a small video. But can you see her eyes are having a little bit of puffy appearance? Correct? And now look at her eyes. Now they look more tensed. This is a sign of over sedation. So you take your patient from here, normal looking, to here, where they are sedated, to this, where the sedation gets more. The child is slowly getting uncomfortable. The forehead is again starting to get wrinkled. This is the stage you should avoid. You should not get into this. This is a safe stage to do your procedure, to start your local anesthesia. Okay. So what are the signs of over sedation? Obviously increased movement, increased rate of respiration, increased sweating, lacrimation, and sleepiness. You know, your patient shouldn't feel sleepy. They should be unaware of the surrounding. That is the criteria you need to achieve. Sweating increases, okay, and they feel nauseatic. Again, that is a criteria which I have experienced. In fact, my patients have even passed urine on the chair because they have been over sedated. So that's one rule. I'll come to it slowly, but that's one rule you need to, remember to make your patient pass urine before your procedure. Okay, so how do you go about doing it? Now, you introduce the technique, then you give your pre-op instructions. What I give is 2 hours of fasting is good, and ensure that there are no upper respiratory tract infections in the child. Now, all the patients actually, they don't need 2 hours of fasting in my experience, but technically you do need 2 hours of fasting before nitrous oxide. What I tell the patient is to avoid fatty food before doing the procedure. Avoid having a biryani or avoid having puri masala and all those things before your nitrous oxide procedure, because that is going to cause some amount of nausea. But otherwise, not really fasting for 2 hours. Then you obviously need an informed consent. Start your titration, do your monitoring, do your procedure, and then go to recovery. So that's the order that I follow. So what is the routine that I follow? First, you check the equipment each morning. And trust me, this is done each morning. I have an assistant assigned who goes, opens the cylinder, checks the pressure is okay, and comes back, whether we have the case or no under nitrous oxide. Now, why it is done this way? Because I tell her, if you don't have a routine, it's not going to be done. Otherwise, suddenly we have a case and we'll have to, check, and we may find out the gas is empty. We need to change the cylinder. So every day as a routine, this is done in the morning. Then what happens? Then you ask the patient to have a light meal, use the restroom immediately pre-operative, sign the informed consent, get a good update the medical history again, set up a relaxing surrounding, comfortable surrounding for the patient, and then go ahead with introducing the mask. So what do I do while introducing the mask? Now, if you see, I'm just putting the mask on my nose, and then now I'm taking it slowly to the patient's nose. So this patient is quite a smiley patient, not a very bad patient, not a very difficult patient to introduce the mask to, but always introduce the mask. If you can see, I only have the mask in my hand. I have not attached it to the breathing apparatus. So once you show just the nose to the patient, they become more accepting of the mask rather than seeing the entire assembly on their face. So that is the significance of this video. What I'm trying to tell you is introduce the mask alone and then go to the breathing apparatus. So once your child is ready to wear the mask, what do? Always switch on your gas flow, switch on your machine, start your oxygen, and only then keep the mask on the patient's nose. Don't suffocate the patient with a mask with no air entry. That is again something which is going to be a put off to most of the children. So we have two techniques of doing this. One is the standard titration technique and second is the rapid titration technique. So let's go to the standard titration technique. The first phase is the introduction phase, where you give 100% oxygen to the patient. So at this stage, what do? You establish the flow rate for the patient. Now, most adults will have a flow rate between 7 to 8 liters per minute and children 5 to 6. So with experience, you will get to judge. You actually have formulas to find out the tidal volume of kids, but I don't do all that. I just set a rate between 5 to 6 for children. I take it a little less, between 4 to 5 for very small children, and 7 to 8 for adult patients, right? If your machine has a reservoir bag, mine doesn't, so I don't need to do this step. But if your machine has a reservoir bag, fill it with 100% oxygen using the oxygen flush button, and then start the oxygen flow and put the mask on the patient's nose. Slowly, right? You incrementally increase the nitrous oxide concentration. So start from 10, after 3 minutes, go to 20, after 3 minutes, go to 30. So do you keep doing this every 3 minutes? No, it is in these 3 minutes that you check for the patient's reaction. You check if the forehead is getting relaxed. You check if the eyes are getting a glassy appearance, right? So whenever your forehead is relaxed, patient is relaxed, eyes are getting a glassy appearance, stop increasing the nitrous oxide, because that is all sedation that you need to do your procedure. So once your patient reaches plane 2, you stop giving nitrous oxide. You maintain it. You go to the maintenance phase of nitrous oxide and start your treatment. See, this is again the challenge in nitrous oxide. If you're a busy practitioner who's used to doing patients very quickly, this is going to eat up your time, right? So you need to first accept that you are giving a value addition to your practice. So you need some time also. If you are ready to spend time with the patient, only then go ahead with all this, right? Because this induction itself will take a good 10 minutes, where you make the child used to the mask, give 100% oxygen for 3 to 5 minutes, wait for 3 minutes between each increment of nitrous oxide. And initially, it's very, very good to wait, start from 10. With practice, you will not. But initially, give only 10% nitrous oxide, wait for 3 minutes, because there are patients who will get sedated with 10-20% nitrous oxide. Okay, so time is another thing that you need when you're doing this procedure. Then you have the injection phase where your child is adequately sedated and your child is ready for the local anesthesia. Again, if you see these 2 points, inject slowly, distract the child. So whatever you do, your injection technique remains the same. You cannot quickly press the injection inside. How you can give a good LA is by following all the principles of giving a good LA, whether you're doing it under nitrous or whether you're not doing it under nitrous. So once you finish this, most of your tension, I think you will be more relaxed than the patient once this stage is over, and then go ahead and do your procedure. So just again, I have a short video on how to give a local anesthesia under nitrous oxide. Now, if you see, I have a patient. This, mind you, is a mildly autistic child who is quite hypermotive when we don't give him nitrous. We've tried doing him without nitrous also. And he becomes extremely cooperative when we give this. If you see, I am giving him an inferior alveolar nerve block for a root canal procedure on one of his teeth. The root canal procedure is going to be done by my husband, who's an endodontist. And I'm just doing the behavior management for the child because he's a mildly autistic patient. So if you see, this patient is not moving at all, right? He is following all my instructions. I'm asking him to open wide. He's doing that. And here, if you concentrate, whatever technique I use, I still have my assistant passively restraining him, right? Because this is very important. Suddenly the child moves his hand. I don't want to be helpless over there. So the assistant doesn't grab him or, physically restrain him. She just passively stays near him. She pats his hand. If you can notice what she's doing, she's not even holding the child. She's just touching the child. So the parent also is very happy when we do it this way instead of restraining the child completely for a local anesthesia. Now, mind you, I have not speeded up this video just to show you the amount of time that I've taken to actually administer the local anesthesia in this child. It should be done slowly. It need not be done at a very high speed. Many of the times we are scared that we're going to finish the procedure quickly, so we inject very fast and it's very painful. So if you do a job slowly, especially local anesthesia in children, they do tend to cooperate. Okay, so this is an example of how nitrous oxide is helping the patient relax and cooperate for your dental procedure. So now the needle is out and the patient is still with me. He's not at all become disruptive. Okay, so then is you go to your procedure. It is the maintenance phase, and after that is the recovery. So before that, I'll just talk about the other technique, that is the rapid induction technique. In the rapid induction technique, it is used in hypomotive children where both your nose and mouth need to be covered. Now again, in India, we don't get these masks where both nose and mask can be covered in the dental clinic, right? The mask actually which is used in hospitals, right? In OT rooms, that is the mask that you need to use while doing the rapid induction technique. What practitioners modify this technique is they just give a high dose of nitrous oxide. They say 60% of nitrous oxide initially itself, so that the child gets sedated. But if you do that in a child who's crying loudly, it doesn't really work. It will work only if you cover the nose and the mouth of the child with the mask. So rapid induction technique is a little difficult to follow in our kind of setting. So then coming to the monitoring, what kind of devices do you need for monitoring? You just need a pulse oximeter and ensure that the partial pressure of oxygen is more than 95 when you are working on the patient. So that's all other monitoring that you need to use. You can observe the chest movements of the child. You can observe the movements of the bag, but this will give you a fair and clear idea on whether the patient is with you or no. And the last phase, that is recovery, when you have finished your procedure, again as induction, Same way, you give 100% oxygen for 3 to 5 minutes to prevent a condition called diffusion hypoxia. So what exactly is diffusion hypoxia? As the patient is exhaling out all the nitrous from the lungs, there shouldn't be a point of time when the lungs are hypooxygenated, right? So to prevent this diffusion hypoxia, it happens at the time of diffusion of nitrous from the lungs outside. So that time, so that the lungs don't be without oxygen, you need to administer 100% oxygen for 3 to 5 minutes. So that's all is about diffusion hypoxia. Okay, so remember that you give on termination 100% oxygen, allow the patient to sit up for some time and then get up and go to the waiting area. Verbal and written post-operative instructions should be given to the patient. Recovery must be assessed as being complete by using the response to the following question. What is it? That is the motor coordination of the patient should be checked. Each test is asking the patient to move his finger and getting back into the center. It is something which a patient with good motor coordination only will be able to do. Check the vital signs and then leave the patient. So how do you keep the record? You have the date of administration, the time, preoperative vital signs, the percentage or the total flow in liters that you set before giving your oxygen, pre-medication if used any. I don't use any, but there are practitioners who use pre-medication. There was a question on that and I won't be able to answer that because I don't use pre-medication in my practice. And the time the actual procedure started, the time it actually ended, the concentration of nitrous that was given, any pertinent occurrences, the time the patient has left the office, condition while leaving the office, and the people who had attended your procedure. So this is how your patient is going to depart after your procedure is over. Okay, so let's go ahead and watch this where I'm doing the procedure in the child under nitrous oxide. So first I've introduced the nose and then I have given the patient the entire apparatus. So the patient is given the apparatus only after introduction to the nose. And before putting this nose on, the gas has already been switched on. I will show you how that happens in the following slides. And once the patient has inhaled your 100% oxygen for 3 to 5 minutes, that is when you give them all the instructions and slowly start the titration. Right? So while titrating, if you concentrate on this portion, I had adjusted the to 0, given 100% oxygen and slowly started giving 10% of nitrous oxide, 20, 30, right? In this case, I had taken the nitrous level to around 40% of nitrous, right? Now see again here, this patient is needing a little bit of reassurance from me, right? She is not gone into plane 2 of sedation. So I am again waiting, talking to her so that she goes into plane 2 of sedation. So if you see, my behavior management is going on all the time. And again here, now you can see the patient move a little bit as soon as I inject. But again, she's able to cope with the injection very, very well without moving her hands or legs. If you see, my assistant again has stabilized her a little bit and now she's all okay. She's allowing me to do the procedure. A few multiple fillings for this child and root canal maybe. So now the child being sedated is not moving and now we're almost to the end of the procedure. So multiple things in single appointment can easily be done with nitrous oxide. And once this happens, the child is ready to, even for the next appointments. And next appointments, you need lesser gas sometimes. Okay, so you have two types of equipments. We have a central equipment and we have a portable equipment. Now, if you see, this side is the central equipment. This side is a portable kind of a device, and this is exactly what my clinic has. If you see this portable picture over here, it has no cylinders attached to it. All cylinders are outside. That's how our practice is. Our cylinders are kept outside the clinic. So you have portable and centralized, and in both you have analog flow meter and digital flow meter. So this is your flow meter, the main component of your device, where you have a nitrous oxide flow meter tube, you have an oxygen flow meter tube, you have a mixer. This is called the mixer dial, and here you have the flow control knob. This switch is the emergency oxygen flush button, where you need to give 100% oxygen immediately to the patient, and this is the emergency air intake valve. This is a digital kind of nitrous oxide machine, and again this is a patient. If you concentrate on the eyes, glassy appearance, sedated eyes. This is what I want all of you to take back after today's class. And somebody asked me on the type of the mask. The mask that I use is a low profile mask. It is a single mask. It is not a non-rebreathing mask. But the ideal mask that is supposed to be used is a non-rebreathing kind of a mask, where the inhaled and the exhaled air don't mix up with each other. So that will ensure better concentration of nitrous oxide when inhaled. This is my kind of mask, the single mask. There is only one inlet and one outlet. It's the same. Inlet outlet is the same for inhaled and exhaled gases. So there's a lot of mixing of inhaled and exhaled gases. Also, there are a lot of sources for leakage in this kind of mask. So it's always better to use a non-rebreathing kind of a mask, which comes with a Matrix machine. Nowadays, even my machine has given me, the Concert machine has also given me a non-rebreathing mask, but I'm yet to use it. And these are the safety features that are actually, part of your nitrous oxide system. So of these two are very, very important. The pin index safety system and the diameter index safety system. Now, this is what is the pin index safety system. If you can see, these pins are a little angulated for the nitrous and they are straight for the oxygen. So the oxygen cylinder can never be inserted into the nitrous tubing even by mistake. It will never get inside because of this orientation. And this is what you need to remember when you are doing your sedation practice. Now, what I have in the clinic is a diameter index safety system. Now, if you concentrate on this video again, this is hexagonal and this is round, right? So again, I'm playing the video. The round is never going to enter the hexagonal system, and the hexagonal will never enter the round system. Even the color coding is different so that you don't go wrong by mistake also. So this safety feature will allow that nitrous and oxygen never ever get mixed with each other. So you can never give nitrous for oxygen or oxygen for nitrous in this machine. That is one beautiful thing that they have done, right? Already we are so scared to enter into this. If there was any mixing that was happening, nobody would even venture into it. Now, another thing that could happen is suddenly your oxygen cylinder gets over, and your patient will only be inhaling 100% oxygen. Well, no, that is never going to happen again in this machine. Now, if you see, I have opened both the cylinders in this video, and once I open both the cylinders, I'm setting the flow control knob. I'm opening it. I have set it to a particular level. In this case, setting it to 6 liters per minute. And then slowly I start the nitrous, delivering the nitrous. Now I'm giving the patient 40% nitrous. Now what I do, I am going to close the nitrous oxide cylinder, right? So I'm closing the nitrous oxide cylinder here. And as soon as I close the cylinder, can you see this ball has come down? The nitrous oxide ball has come down. But the oxygen is where it is. So the patient is still inhaling oxygen. So if your nitrous cylinder gets over, you don't have to worry. Patient is inhaling oxygen. He will never be out of oxygen. But what if your oxygen cylinder gas inside. You can ensure.
Hello, ma'am. There's a slight interruption in your voice, ma'am. Hello, ma'am. Hello, ma'am.
Yeah.
Yes, ma'am. You're back on track.
Okay. So I think I had lost my connection.
Yes, ma'am. Just a while ago.
So I was talking about the adverse effects on patients, and that's just nausea, vomiting, roller coaster. What is a roller coaster effect? It's an effect where you increase the nitrous, then bring it down, then increase it again, then bring it down. That is something which you shouldn't be getting the patient on, right? So if you have finished your procedure, you're about to finish, get it down, then don't increase the nitrous. It's better you do the procedure some other day. Okay. So, what happens to the personnel, however? There are effects like pernicious anemia, spontaneous abortions. So, pregnant doctors better be away from this unit. And chronic exposure is more than 8 hours per week, right? So, that's ample time. So, what are safe practices? Check your cylinders, check for leaks, service them, check your nasal hood. Don't allow a lot of patient movement, and try to use a scavenging equipment. Again, something which is not very popular in our country. You need to scavenge the exhausted nitrous, right? The nitrous which the patient exhales, it should go out of your clinic. Nitrous being a heavier gas will settle down. So you can place exhaust fans at lower levels in your clinic. Again, this is all possible when it's your own building and you can design it in a way that your nitrous gets out of the practice. And try to avoid doing it under air conditioning. Again, difficult in our country, but you can always try. So use a good suction and keep scavenging at floor level. And discourage mouth breathing, right? That is one thing you can easily do with your patient. Discourage mouth breathing and minimize conversation. So comprehensive care increases nitrous oxide levels. So try to keep your procedures short and limit the duration of treatment. And so that is going to get closer to the safety margin, right? So what does it take home from this class is when used alone, nitrous oxide is very safe. Communicative behavior guidance is the hallmark of a successful sedation practice, and proper case selection will influence your success. Maintain your equipment properly, and that is necessary for patient as well as personal protection. So thank you very much.
Hello, ma'am. Thank you for the wonderful session. So now we have questions for you, ma'am. Ma'am, the first question is from Miss Abarna. Ma'am, what happens if oxygen cylinder is over? I think you've answered the question throughout, ma'am. So we'll move on to the next question from Dr. Manisha Nair. Is there any dosimeter to check our exposures, ma'am?
There is, but again, not in our country. There are dosimeters to check the exposure of nitrous oxide, room dosimeters to check the exposure to nitrous oxide in the room. So it's not a personal badge or anything, but you can check the amount of nitrous oxide in the room. But again, it's not available here.
Okay, ma'am. My next question is from Dr. Sangeeta. Can we administer this in ADHD patients? ADHD patients.
You can administer ADHD patient, mild ADHD patient. Very severe ADHD, you will have to restrain them. There is a good chance that they get sick. Actually, the children who have special needs, like neurological special needs, like ADHD, autism, learning disability, are very good candidates for nitrous oxide oxygen. They do get sedated very well when you use the right percentage of nitrous oxide.
The next question is from Dr. Shivanki. Is it necessary to continue all the appointments of child in conscious sedation if patient has one appointment in conscious sedation?
Not at all. There's no such regulation. You can do as per the situation demands. If the child is able to cooperate without nitrous oxide, you don't need to use nitrous oxide, right? There's no rule that you have to use it for all the appointments.
Thank you, ma'am. Ma'am, the last question for the day from Dr. Manisha. Can you please tell us about scavenger system?
Scavenger system is like a suction which is attached to the exhaust pipe or the waste pipe of your chair, and that will suck out the gas exhaled by the patient at the rate of 45 liters per minute. So the suction that we are having is a very high rate, around 200, 250, more than that. You need to step it down to 45, right? And that I don't have in my practice. I'm just looking to make one, but it's not yet out in most of the clinics.
And also, ma'am, a final one. Are there any specific guidelines for NPO, ma'am?
There are guidelines for NPO, just like guidelines. You need to avoid, you can have liquids 4 hours prior, water 3 hours prior, and solid food 2 hours prior. I mean, you can have water up to 2 hours and stop all solid food before that. But again, it is not very critical if you're doing only nitrous oxide in your practice. If you are mixing it with other, but otherwise, it's not mandatory at all. It's better. You can avoid nausea, vomiting. You can avoid such episodes in your practice.
So thank you, ma'am, for being with Online Dentistry. And here we come to the end of our session. So stay tuned to the next 4th Wednesday for another punching session from Online Dentistry. Good night.
Thank you.